I won't even respond to that, John. Bridget, first of all, I'd like to thank David and the organising committee for giving me the privilege of speaking to you today. And I'm going to talk a little bit about the legislation that's going through the Senate at the moment. And as a consequence of that, there was a big report produced by the HIQA, and I'm just going to go through that report and outline some of the details. So the bill was called the Public Health Availability of Defibrillators Bill. And I'm going to talk a little bit about the bill, about the health technology assessment, what it involves, a little bit about the OHCAR data that was used, the evidence that's out there for public access defibrillation, what the cost is, the ethics, the legalities of it, which raises issues, and eventually what the advice to the minister was at the end of the day. So this bill was tabled in May of 2013 by a number of the senators, John Crown, David Norris, Fergal Quinn, Sean Barrett, and Ronan Meehan. And what happens, what the bill actually said was it identified the areas where you should have an AED. So where they should be installed, they should be maintained, and staff should be trained in the use of these defibrillators. There were exemptions from civil liability within the bill. There were offences if they weren't maintained and so on. And it was deemed that the Health and Safety Authority would ensure compliance with the legislation. Now, some people had a little difficulty with that, and they felt that there would have to be changes again to the Health and Safety Act to allow them to comply with all the issues in this bill. So where are the designated places? Well, it's all the obvious places, and they listed all of these places where they should have defibrillators. There was also areas where more than 100 people would be expected to gather per day, and there were individual areas at the discretion of the minister where they should be installed. They should be easily available. Now, this is a problem for a lot of buildings, a lot of public buildings, where they're only open for office hours. So at weekends and in evenings, these were not going to be available. So this was going to be an issue as to how you're going to improve the access. There was protection for both the owner within the bill and for the people who are actually using the defibrillator. So what happened? Well, the way this happens is the bill is read through the Senate on a number of occasions. And during the second stage, the Minister for Health is obviously invited because it's going to be affecting his department. So he takes the bill, he answers questions from the other senators, and he then has to get the approval of government. So he felt he needed more information, so he asked HIQA to do a health technology assessment on this public access defibrillation. So the health technology assessment HIQA set up an expert advisory group under the chair of Maureen Ryan, who's one of their staff. And it took a lot of people, from a lot of specialties, pre-hospital care, the ambulance service, Resource Council UK were there because of their experience with PAD programs in the UK, and so on. So this group met. Now, what does this health technology assessment involve? Well, it's really looking at what the best outcome is for various different interventions, and is it value for money? Because clearly there isn't money for everything, so we have to try and spend the money where we feel it's going to have the greatest impact. So it's looking for the best use of resources, and it evaluates, clinical and cost effectiveness. So this gets very technical and very complicated when the financiers and the accountants and the economists get involved, and what is value for money, and there's, I suppose, ethics around that as well. But it looks at drugs, equipment, diagnostic techniques, and health promotion activities. So what they were asked to do was to advise the minister, what was the best program, what was the international evidence, what was the cost, are there safety issues, what was the budget impact, what is this going to cost us over, say, 5 years, and raise, the ethical issues as well. So the methodology was they established the terms of reference, they set up the advisory group, they systematically reviewed the evidence and did this to some incredible degree. Two of the staff there, Pat Moran and Conor Teljur, the senior statistician, went through the evidence in an extensive degree. And there's a lot of evidence out there about public access defibrillation, but when you actually look at the randomized controlled trials and compare it with what's existing there compared with the existing EMS service, there's actually very little. And there were really only 2 studies that came out as being strong evidence supporting public access defibrillation. Now, one of those studies was actually for police first responders, and there was no evidence that they actually made any benefit. The other study I'll just mention briefly. Looking at what evidence do we have for Ireland? Well, luckily we have the OHCAR database, which Carla referred to earlier. Now, when we were going through this, we had the data for the year 2012. And as the report was being finalised, the 2013 data was available. So they made the adjustments, so there is actually 2 years of OHCAR data supporting this. Looked at the economic evaluation, the budget impact analysis, and then when the report was finally issued, they put it out for public consultation, and it was published on their website, and then they got a lot of responses from that, and they produced another report, and each of the questions that were raised, they answered each question individually, and that's another report that is out there. So a very detailed process in which they went through. And at the end of all that, they took those public comments, included it in the initial report, and then produced the final report, and then it has now been submitted to the Minister. So what is the data? Well, we saw a little bit of this before. About 800 are attended to by EMS in Ireland. 70% occur at home, 20% VF rhythm, 5.8% survival to hospital discharge. Now, the international evidence would be around 7.1, 7.2%, so it's not particularly good anywhere, and this is the problem. The big issue is, this collapse to shock delivery, and that is the sooner that first shock gets in is the major determinant in the outcome. And where should they be placed? Well, ERC will say it should be where you expect a cardiac arrest every 2 years, or the AHA, every 5 years. But if you really want the evidence, for rapid defibrillation and it works, you've got to go to the casinos in Las Vegas, where they have a very smooth operation in the MGM and Wynn resorts. And if they will have a response time on the casino floor of 3 minutes. The security officers are trained in heart saver AED, and they have a response time on the floor, the casino floor, of 3 minutes. And they have a 70% survival to discharge rate, which is incredible. If you're in the resort and you're in the hotel, the shops, the restaurants around the casinos, the response times are 4 minutes and your survival is 42%. So you can see even the difference that the minute actually makes. So this really is compelling evidence that it's those first few minutes are of essence. The Manitoba Act is really the one that the Irish legislation has been modelled on, and that was produced in January of 2014. All the AEDs were registered with the Heart and Stroke Foundation in Manitoba. They were linked with the EMS, and they have the legislation to protect the providers. So it's very similar to the one that we have. We've seen this earlier. You can see this is the OHCAR data of where the arrests are actually occurring, where those 800 arrests occur. Obviously in the major population areas, but there's a lot of dots out there that aren't in those major population areas. And this is the problem, getting to these people in those first few minutes. This is where the locations of these out-of-hospital arrests, and probably the most striking thing, well, most of them occur at home, but in public, only about 16 to 17% actually occur in public. So, putting all these defibrillators out there, is it going to make a huge impact? The numbers. Now, this is our best evidence, really. This is OHCAR data on the survival. And if you've got bystander CPR, your survival to hospital discharge is 5.5%. If you're relying on EMS responder, it's going to be 4%. But if you have your bystander CPR and your AED, you're up to 13.4%. Now, this is really compelling data about having bystander CPR and having an AED program and having the AEDs out there. So what to say, we've seen this earlier, the response times are the problem. Those rural areas are just so difficult to get to, and that is the issue. As 16% will the response time is less than 5 minutes. So, getting there is the big issue. The community first responders, there are about 100 linked to the EMS system, but there are many out there that aren't, and this is one of the problems. And obviously, this group, this organization is going to make a huge impact, I think, on the way this goes forward. So how many are trained? So there was a study in 2008 that estimated that about 24% of the population in Ireland are BLS trained. The OHCAR data will say that 60% of them will have bystander CPR in non-EMS witness. So that's not too bad. So how many defibs do we have here? Well, they contacted all the manufacturers, and they estimate that about 15,000 have been sold from 1998 until today. Now, with the average lifespan of a defibrillator, about 9 years or 8 years, they estimate that about 9,000 of those are probably operational, which would give us an impact of 196 AEDs per 100,000 population. And that, the other programs in the world, well, they have had programs. I mean, Copenhagen 92, Denmark 273, Japan 234. So we're not that far off, even without a formal scheme, of having the number of defibs there. And where are they? Well, they're the obvious places where you probably know where these are. Now, the one problem is we don't know where they are for definite. We don't know the locations, EMS don't know the locations, and that is a huge issue. So there's no register, and the only link is really through the community first responder groups who will have the defibs. So clearly that is an area to improve. So they took all of the designated places that were the legislation said, well, you should have a defib here. And there's a directory called the Geo Directory, which maps every location, industrial activity in the country to a specific address. So they can actually get a list of, take the list of where the legislation said these defibs should go, and you can actually work out, in transport, should be 639 going into transport locations in the country. And they were able to estimate where these defibrillators should go if the legislation was brought in. And the bottom line is 43,000 AEDs would be required to cover all the requirements of the legislation, which is a huge number. Now, they decided, well, clearly this is a huge number. This is going to cost a huge amount of money. So they looked at a number of different schemes, and they cut it back and said, well, what about if we only had 15%? And what if we had 20% or 25%? And they went up to 55%. And they used these different models and estimated all their cost effectiveness and survival statistics based on these different schemes. And that's how they have so many of the different schemes. So it's quite probable that one of these will be selected rather than going for the full legislation. So what if we went with the legislation, we would have 1,030 AEDs per 100,000 inhabitants. That's almost 3 times any of the published PAD schemes around the world. I mean, we'd have the highest concentration of AEDs on the planet if they go with the legislation. Now, what's the evidence? Now, probably the landmark trial that everybody refers to is this study, the PAD trial that came out in 2004. And this is the one that showed that you could double your survival if you had a public access defibrillation program in place. But there were a number of caveats to this, and this was analysed in particular by the information scientists and the statisticians and the HTA. Now, this group, it was a randomised controlled trial. They had 993 community groups. There was CPR plus AED or CPR only. There was 11,000 trained volunteers in AED, and that's the important thing. All of these people were trained. And they located the AEDs within 3 minutes of where the potential arrests would be. Now, the way they reported the data was they reported it on the absolute number of events. And the rationale was to avoid bias in the interpretation. But the problem with that is that you can actually overcompensate by trying to adjust for a bias that may or may not be there. And the scientists at the HTA felt that this may not be. What if we didn't use that as a denominator and looked at just the number of areas where an actual arrest was called and compared those two? So in the control group, there was more arrests were in residential areas. Now remember that these AEDs were placed in mainly public locations. There was a lot more dead on arrivals in the control group as well. So you do have, a potential to the interventional group to look better than it actually is. So if you use the denominator as all arrests, all resuscitations, if you don't use that, you may overestimate the effect of the intervention. But if you calculate it as that rate, they found that there was no significant difference in the outcome. So there you have the interpretation of this. This is, widely, in editorials throughout the evidence, the literature, this trial is put forward as this is the one. And yet, if you just look at it and dig down and delve into it, the significance is not as you would expect. And then you've got to worry about, well, can we apply that trial to this? Does it necessarily mean because this paper is there that this is going to work in Ireland? Well, if you look at the average response times in any of these papers, they're about 7.5 minutes. 70% of arrests in Ireland are occurring at home. In the trial, 70% of the arrests were occurring in public locations. So, the effect of, taking that study and trying to say, yes, it'll work here, may not actually be true. So the cost, they went into tremendous detail. It goes into, how much a hospital stay is, how much the implantable defibrillator is, the loss of earnings and all of these things. So they go into some considerable cost. Now, what will it mean? So how many more lives would be saved if they put all of these defibrillators? They had their 43,000 defibrillators out there. They estimate with the legislation that an extra 10 lives would be saved per year. And if you go with the 15% scheme, you'll save an extra 2. And the cost per life saved on average, if you go with the 15%, is almost €500,000. And if you go with the legislation, the cost is $1.5 million. Now that's a lot of money. We were told at the outset in this group that if this scheme is brought in, make no mistake, there's no money. The money has to come from somewhere else. So it'll have to be taken from other schemes, some other project to put into this. So it's all about distributing resources and where your best use of your economic resources are. Now, this is what the economists use. They look at this quality-adjusted life year. And when they're trying to introduce an intervention or a drug or whatever, they look at this actual, this quality-adjusted life year. And although it's not a hard and fast evidence, they use the figure of about €45,000. And if it's €45,000 per year, if it's above that, they say, maybe that's too expensive. If it's below it, okay, we'll go with this. This is effective. This is a good use of our resources. So the cost. So taking that 45,000 into account, if you look at the cost for the 15% scheme, almost €95,000, and at the legislation, it's almost €1 million per quality-adjusted life year. So certainly, from an economy point of view, this is not looking too good. And what's going to be the cost to the different organizations? Well, it's going to fall on the health service, the public sector, and mainly the private sector. And if they go with the legislation, it'll cost the health service about $2.5 million. It'll cost the public sector, all the public buildings that'll have to be equipped, about $17 million. And it'll cost the private sector about $85 million. Now, this is projected over 5 years. So it's a grand total of about €106 million that this will cost to implement according to the legislation over the 5 years. The ethics, there is the consent and there is implied consent. There is this doctrine of necessity. You have to resuscitate. It's necessary to resuscitate to actually get a survival. And for non-professionals, you have to act in a reasonable manner, and that's sort of the law, as long as you act within a reasonable manner. DNR, if it's obvious at the time of the arrest, you have to respect those wishes. But if somebody was resuscitated and they say, I didn't want to be resuscitated or whatever, the lawyers would say this would be a claim for wrongful life, but they feel that it's unlikely to succeed in the Irish courts on the basis that this is a harm that should not be compensated for. Now, in addition to this bill, there's also legislation, there's a Civil Law Act, which actually has a Good Samaritan clause in it, which actually will state that you are not liable if you acted in good faith and without gross negligence. And then there's common law defense as well, in that you have a duty of care that is of a reasonable standard expected of a person in that position. Now, that means that, the more qualified you are, the higher level of care you have to provide. But you're compared to an equivalent person in your position. The actual bill will protect the owner from civil liability of any harm or damage, provided that they maintain it and there isn't any gross negligence. There is some liability with the machine fault, failing to maintain it. But interestingly, there isn't anything in there about failing to use it. So so you can have it on the wall, you can have the staff trained, but you're not compelled to actually use the device. I went to a meeting in June last year, the ECCU conference, which is run by the Citizen CPR group in the States. And they are very much behind a lot of the legislation that drives the PAD programs in the US. And one of their big arguments is that none of their legislation has a statutory requirement or obligation to use the defibrillator. Now, they want to bring that in. They want to make it mandatory that if that defib's on the wall, that you've got to use it. You're mandated by law to use it. But it's not there, and it's not in the Irish legislation either. Now, the lawyers feel that in this country feel that it would impose a duty to rescue, and that raises a whole kind of complexities in the long term. So, in summary, the concept is correct. It's supported by a lot of community groups, by a lot of professional organizations, but the evidence is actually quite weak when you actually look at it. If they went ahead according to the legislation, they would save 11 lives per year at considerable cost. It would mean that an extra 38,000 AEDs being placed. I'm sure Physio-Control and Medtronic would be delighted, and Philips would be delighted at this. But we'd have the highest concentration of AEDs in the world. So what about the other PAD programs? I mean, do they work? If you put all those AEDs out there, does it actually, are they actually used? Well, this was a study by Deakins and published in Heart last year. And they looked at the experience in Hampshire in the UK. Now, they had a public access defibrillation program for 12 years. They had 673 AEDs deployed in 278 locations. They had a database linked in with EMS. They knew where the AEDs were. They had 1,000 arrests in a one-year period. And AED deployment, 1.7%. That was... And it's not just, the UK. Japan, huge database, over 300,000 arrests. I think they're up at 400 now. AED deployment, 3.7%, where they have an actual PAD program in place. The ROSC Consortium in the USA, Canada, AED deployment, 2%. So what was the advice to the minister? So at the end, they produced the report. They gave him the details, what the survival rate, basically, we had a number of lives that was saved, what it was going to cost, the cost, economic cost for the private sector, the public sector, and 105 million euro over 5 years. The magnitude of the impact is quite difficult to estimate because you've already got, 9,000 defibs out there. You've already got a community first responder group out there. So, even if you did all of this, would you make that significant impact? So it may not actually be as effective as is led to believe in this report. What they did suggest was that if you had a location-specific instance, you could increase the cost effectiveness. So in other words, if you could map the areas where there was more arrests occurring and put your AEDs there. But that would need multiple years of OHCAR data to actually locate those areas. There was other issues that weren't covered in the bill as to the quality assurance, the compliance with the legislation, the Health and Safety Act, performance evaluation, and these really are essential, to show that this is actually working. There wasn't anything about, linking with the EMS or with the register, which was felt by the group to be extremely, extremely important. The other issue, but in particular, there was no statutory obligation in there to actually use the AD, the negligence, and so on. So what next? So the report has now gone back to the minister. So now he takes the report and he says, okay, well, maybe we'll go with this scheme or that scheme. We'll add this, we won't. And he brings it back to the Senate, and then they debate it. And then they decide on a consensus, okay, this is the bill as we push it forward. So then it goes from the Senate to the Dáil, and then they do the same thing. They have multiple readings, and it's presented there in the opposition, and everybody has an opportunity to pass comment, and eventually you get a consensus opinion. It's voted upon. If it's passed, it then goes to the President, and it's signed into law. So clearly it's going to take a little while before this happens. But to me, I think one of the issues is, even though you have PAD programs in place, are they going to actually be used? And one of the issues, there was an editorial on the back of that Deacon's Hampshire study by Tom Ray and by Mickey Eisenberg, who with Douglas Chamberlain would be the gods of resuscitation. And they were sort of decrying this poor uptake in the use of AEDs, and sort of likened it to the fire extinguisher. And maybe beside the fire extinguisher we should have the AED, and maybe because the AEDs are too expensive, they cost maybe €1,000, whatever. Whereas with a fire extinguisher, people and society will accept maybe 100, 200, euros to pay for a smoke alarm and a fire extinguisher and have it on a wall. So maybe if you had 100 or 200 euro AED, like we have disposable barbecues, could we have a disposable defibrillator or a one-shot defibrillator and throw it out? And they just feel that this is the sort of way that maybe this is the way we need to be going, because certainly having all the AEDs is just not working at the moment. So certainly establishing the register and the database is the important thing. Facilitate the CFO programs. Clearly we heard all of that this morning. One thing, David Slattery, who is the medical director for the casinos and the MGM and the Wynn resorts in Las Vegas, would say that his security officers who are trained in HeartSaver AED are the Delta Force, or the special forces for the first few minutes of the arrest. And I would say the CFO programs and you people are our Delta Force for the first 5 minutes of resuscitation in the community. And I think that has to be promoted, and that is a big move forward, I think, that we have to take. The other issue, the final word I'd say, is just CPR AED in schools. At that meeting in June, at that time, there were 15 states in the US that had legislation mandating CPR AED in schools. And they're pushing it all the time. And I think certainly if you have CPR AED in schools, you're training the entire population. I mean, most people don't know what to do in a collapse. No, most people don't know what an AED is. If you train the entire population through the kids in school, at least you'll get it into a culture and you'll actually improve. And I think this is one area that would be of huge benefit if they do bring in the legislation. It's to make sure that the schools are included. I'm glad that we ran over. We were late starting because it meant then I couldn't be blamed for delaying the meeting. So thank you for your attention.